Okay, good afternoon, ladies and gentlemen. Welcome to this webinar, ICTCT webinar. My name is Alexey Laureshin. I'm a part of the ICTCT steering committee. Staying the usual moderator of our webinars, he had some collision in his schedule, so he asked me to replace him. So very much welcome to this a little bit unusual talk, because today's speaker is actually active operating surgeon from St. Stephen's Hospital in New Delhi in India. It was actually my idea to invite him to give us a little bit connection to reality. Very often we as traffic researchers think about accidents as numbers, as statistics, but I think it would be a good reminder for us that actually there are real people and real pain behind that. Before I fully introduced the speaker, just a couple of words about the ICTCT itself. So we are an association of traffic safety researchers. We have been around for quite some time, starting from late 1970s, officially registered in 1988. And yeah, now we're approaching our 40 years jubileum. Also, we do have some of traditional activities. One of them is the annual conference, and this year it will be in Zagreb in Croatia. I actually am not fully sure what is the status. I think submission is closed already, but registrations has not started yet. But you can check the program on our webpage. We do have our webinars, and we do have the next webinar in the pipeline. So it will happen in August, end of August, with Ralph Risser, a former president of ICTCT. So I hope many of you know him well. We do have several subcommittees at the ICTCT, and one of them is the AfroSafe Academy. And AfroSafe Academy has its own activities, and just in less than a month, there will be the third AfroSafe conference held in Lusaka in Zambia. And it sounds a little bit exotic, but I've been there in Zambia, in Lusaka now on several occasions. It's really very interesting place to visit. So submission is closed, registration is still open. So if you have your ways close by, consider joining. Yeah, and to learn more about ICTCT, you are most welcome to visit our webpage, ictct.net, sign up for our newsletters, and also follow us on the social media. Yeah, and also you see here there is a YouTube icon. We do record our webinars, including this one. So by now, there is a pretty impressive collection of talks by quite prominent experts in traffic safety. So I would really recommend you go and visit. So you can go back 5 or 6 years now in time and really to listen. Some of those people are really legends in traffic safety. And back to today's talk, Mathew Varghese. How do I pronounce your surname, actually, Mathew?
Mathew Varghese.
Varghese. Okay, sorry.
Varghese has roots in Greece. Greek name. It's a Greek name. Comes from ergos, means the ground. Varghese, somebody who works on the ground. That's a farmer.
Okay. Thank you for explaining. Mathew is an operating surgeon. He is the head of orthopedic department and St. Stephen's Hospital in New Delhi. He has been the director of the entire hospital for quite some years. as well. And he is expert on injury control, epidemiology of injuries, and pre-hospital care. He is also affiliated with Transportation Research and Injury Prevention Center at IIT Delhi, which is a collaborating center of the World Health Organization in India. He is an author of several books on the subject, and also he received a number of awards for his humanitarian activities. So without much ado, Mathew, now the floor is yours. So I will stop sharing and please take over.
Thank you so much, Alexi. Thank you for inviting me, and thank you for having me here. Can I share my PowerPoint now?
Yes, please.
So when Alexi sent a word to me that, pick on a topic, so I decided that I will talk on pre-hospital care to a group of experts on traffic safety and traffic management. So of different understandings over the years, from practical experience to the actual theoretical understanding. So the first question is, can we save all patients that are injured? Can we save all? No, not possible. Even if the crash occurs in the operating room with all trauma team and all trauma facilities available. So if the answer to the question is not possible, the question then comes, how can we maximize the number of lives saved after trauma? So any intervention that as healthcare professionals we do should be to maximize this number. We accept we cannot save all, but can we maximize this number? So the whole concept of trauma care from roadside to bedside and then back home is a complete spectrum that the patient needs to be taken through and getting back to his work. Let us assume, for the sake of assumption, that we have unlimited resources. We have unlimited use of technology, whether it is regular or artificial intelligence, and we have all the equipment under the sun. Just to understand the science of pre-hospital care, so that we know what we should introduce in the community to maximize the survival of an injured victim of a traffic crash. That's what. So it is only for the sake of convenience that a trauma victim his care is divided into pre-hospital and hospital. But his care should start right from the time he is injured. That is important. We must also not forget that the concepts that form part of modern pre-hospital and hospital care has evolved only in the last 60, 70, 80 years. Just to give an example on the evolution, the understanding of head injury started a little better understanding in the 50s. Understanding on cardiac arrest is 53 onwards. Understanding of cardiopulmonary resuscitation of a cardiac arrest patient, 1960s. Use of hypertonic saline and normal saline as a volume replacement for circulatory compromise from hemorrhage is 1963. Intracranial pressure monitoring in 1976. The ultrasonography, which is ubiquitous all over now, is 1970s. And CT scan, again, a trauma patient's standard protocol for a multi-system injured polytrauma victim is a CT scan of the head, thorax, and abdomen and pelvis. So we don't realize that it has taken years, but only in the last 60 to 70 years. The standard textbook of medicine that we have is Principles of Internal Medicine, which is very popularly the Harrison's textbook. There's a preamble to that book in the beginning, and it starts off with medicine is an ever-changing science. And if we look at that in the last 70, 80 years, science of pre-hospital care and hospital care of the injured and the non-injured has evolved, and we are in a paradigm shift compared to what we did in the 40s and the 50s. The question about pre-hospital care is, do we know the science of pre-hospital care sufficiently enough to emphatically say that we are doing right? Because this is important, because you cannot generate policy for legislation, policy for a public health approach, unless you know what is the best to save the maximum number of people. And what is it that we need to know to ensure that we do not harm anybody? Primum non nocirum is the Hippocratic oath that we all take. So we need to make sure that we have that. My interest in this whole project started with the agricultural injuries project, which we did in the transportation. Those days, it was not a transportation, it was a center for biomedical engineering. And we had a project looking at agricultural injuries. The agricultural injury patients, they were serious injuries, thresher injuries, mangled extremities, and they would come to the hospital from the rural areas, 2, 3 hours down the line, not within an hour that we talk about golden hour for these trauma victims. And Professor Dinesh Mohan, who was my mentor, he asked me, you must be seeing a lot of complications. So the most common complication that we saw were the infections of these crush injury patients. It is only when we did the research project and we went into the community, we realized this thresher injury causing mangled extremities with potential for shock and other problems is likely to happen. And even the doctors did not know about it. I also did not know it till we went into the thing. So that helped me understand, going into details, going into the field to understand what is happening. And that is what provoked me. Why are those mangled extremity severe? At the literature on delayed presentation of injuries, and also looking at what is done in the first aid, what is done in the ambulance, what is done in the hospital. So I did surveys into the hospital records and trying to find out what's happening. We also tried to look at how are my patients of transportation related injuries transported to the hospital. And you would be surprised, in a major city like Delhi, in the year 1989, we had only 4%. If you see this graph, only 4% of patients came by ambulances. 34% came by three-wheelers. Number came by police vehicles and other four-wheel taxis. Whereas the average impression was trauma victims are carried by ambulances. But we were surprised. It's only when I started looking at the ground level that I realized this number is only 4%. And then we looked at they must be coming late. We realized when we looked at the study, 53% of them reached within 30 minutes. 30 minutes. Well within the golden hour, 53% without an ambulance, just by private taxis and other things. It was a huge lesson for us that the patients are picked up by bystanders. The triaging is intuitive. Ambulances are used very frequently. Taxis are very. So we repeated the study in 2004. We were surprised again, expecting that the ambulance numbers, since we are now economically better, we expected the ambulance numbers to be higher. However, we found the ambulance numbers were less than the previous. From 4%, it had gone down to 3%. the three-wheel taxis had gone up to 42, and the police vehicles had gone up to 33% of the victims transported. Fascinating. Our presumption that they would be. So you ask any doctor, how is a trauma victim transported? Most of them would answer ambulances. Ground realities in low and middle income countries can be completely different. So if you improve ambulance services, you would impact only 4 or 3% of those. Today, the number from 2004, 22 years down the line, is probably around 10-11%, not more than that, which means 90% of trauma victims are outside of ambulances. 90%. Then we come to the question whether it is an ambulance or a taxi or a police vehicle, the patient needs a continuum of care. The continuum of care starts with if it is a patient entrapped in a vehicle, extrication from the crash site into a vehicle for transportation becomes important. Then someone decides this one is seriously injured, this has got fractured. So that process of deciding how much is the primary assessment in terms of injury that is patient is such a. And then you the neighborhood nearest clinic or a trauma care, trauma center capacity facility, which means triaging is what is important in these cases, but that's intuitive in these cases. And once the patient is transported to the hospital, he gets to the emergency room, he has a primary assessment, then he has a secondary assessment, has the diagnostics, has definitive management, has continuous monitoring if it is critically injured, and then treated surgically or otherwise, and then rehabilitated and back to work. It is for our sake of convenience, we compartmentalize them into different stages. Practice of modern medicine is increasingly evidence-based. However, many of the interventions that we do are empirical or consensus-based. There is a danger here because consensus guidelines or empirical guidelines may have biases and may not always be the most effective way. Now, there has been a problem in the consensus document that have been generated till recently. The problem has been in emergency care, trying to do randomized controlled trial is a challenge. European Union also has a guideline on this now, doing a randomized control because you can be sued by the patient's relatives that my patient did not get all and therefore I landed up with a. Again, we try to look at what is it that is required in that. In the first place, we need to get the patient out. Extrication. So we found that when we started surveying ambulances in our part of the world, we found that extrication equipment is not sufficiently emphasized. Modern cars are passenger safe. So therefore, when the doors get jammed, getting inside is next to impossible. Retrieving a patient is next to impossible. Fortunately, number of car victims are far less. Unfortunately, the ones injured are more on motorcycles, motorized two-wheelers, or are pedestrians. But even those car ones, you need to have extrication equipment. That is important. So modern equipment can be very fancy, but most people are ignorant in this part of the world on this, whereas this may be the norm in Scandinavia or European Union. You need to understand these details are important. Then you have the classical conventional teaching of ABC of resuscitation: airway, breathing, and circulation. Conventional teaching that we need to ensure there is a clear airway. We need to check whether the patient is breathing once the airway is clear, and then you take care of the circulation. So if he's having a cardiac arrest, cardiopulmonary resuscitation is started off soon after. So that cardiopulmonary resuscitation until recently involved one, a chest compression, that is the chest compression that is standard on the sternum, followed by the mouth to mouth breathing, or if the ambulance has reached, a bag valve ventilation. Now everybody accepted this as a ground reality, and it was continuously emphasized this was it. However, research, a publication in 2010, 11 in Circulation, one of the major journals of the vascular and the cardiac people, uh, showed that the chest compression that we do compresses the chest sufficiently enough to produce negative pressure, have respiratory air oxygen exchange that is sufficient for survival. So the chest compression alone is sufficient if you have maintained a clear airway. You don't need to do mouth to mouth if the ambulance has not reached. You can still do chest compression, providing in a patient having an arrest, the circulation as well as the breathing for survival in these patients. So from ABC to CAB took so many years of evolution of understanding. It is only when the researchers started looking at what is happening, supposing we don't do this, what happens only then? Then the question of what intervention to do other than doing the ABC or the CAB of care. The two broad categories, the basic life support category and the advanced life support category. The basic life support category has basic airway support, protection for the spine, and providing supplemental oxygen. The advanced life support category has, in addition to what we do in the basic life support, intubation, intravenous line, fluid replacement, and medications. Let's look at them one by one. So I already mentioned about clearing of the airway of a head injured patient, of a facial-maxillary injured patient. The airway is clogged with vomiters, with blood, with broken tooth. So you clear that and see whether he is bleeding or not and breathing or not. And then introduce the intubation, introduce the uh, airway support. If advanced life support is to be given, he needs to have an intubation of an endotracheal tube with a bag valve ventilation provided by the emergency medical technician. However, the skill of doing an injured patient, unconscious patient, intubation in the needs licensing, and then put the tube. Even then, you can make mistakes and put the tube in the esophagus rather than that. So there have been studies looking at it. There have been randomized studies. I've only included some of the recent ones, but recent means in the last 2 decades. But the studies, one of the earliest studies that came up was in the 70s and then in the 80s. And in the 90s, when I talked about in a lecture, somebody told me, no, 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 that's all experimental. We can't do it as a practical um, solution. So one of the major Ontario pre-hospital advanced life support study, which was done in Ontario state, clearly showed in GCS less than 9, survival was lower in the advanced life support group, and the pre-hospital advanced life support increased mortality with intubation in these cases. So that's an eye-opener for us to review what we are doing in this setting. Don't accept what is given without reviewing it, re-evaluating it, and seeing what we need to improve there. Again, control of bleeding was the best for circulatory control. The hemorrhage as a cause for mortality is after head injury and CNS injury is the number one denominator for mortality in these patients. Hemorrhage. So different techniques have been evolved. Blood transfusion, we still don't have a sufficiently good artificial blood, good area for research there. Blood is not available sufficiently for these victims. So what do? We go intravenous fluid administration. So the push is in the emergency medical ambulance that is reaching there, those that are able to reach, if you push in for intravenous fluid, let's look at the physiology of intravenous fluids. Normally, when you bleed, you start losing from a closed circuit of your circulatory system, it becomes an open circuit. You start losing blood. As the volume depletes, depending on the percentage of depletion, your heart wants to compensate. It first compensates with a heart rate that increases. Then it compensates with a lowered blood pressure so that the bleeding can be reduced. And then it compensates severe vasoconstriction so that the local blood leak can be further reduced. And then it encourages clot formation. And then you have the sealing of the wound, bleeding areas, And then you have, let's look at in a non-bleeding patient. When you put in an IV line, what happens to these patients? The bleeding is continuously happening, but you're pushing in fluid. As you push in more fluid, your body is cheated into thinking there's nothing wrong there. It maintains the blood pressure, it maintains the heart rate, and it continues to push your system's blood out, reducing the hemoglobin available for oxygenation. Why does it not happen in the practical setting? Why does it not happen? Because the volume of blood in study after volume of fluid in study after study is less than 500 ml, not sufficient to cause this whiteout. However, if you bring in technology to increase this, you're likely to have that kind of a problem. Again, in penetrating truncal injuries, when we looked at those that had intravenous fluids, there was no significant difference in survival, hospital discharge, and complications. On the other hand, there was improved survival with lesser perioperative complication with balanced delay in resuscitation. Today, the understanding is controlled resuscitation strategy is feasible in trauma victims. IV fluids, the protocol, the advanced trauma life support protocol used to be two large bore catheters, one above the diaphragm and one below the diaphragm, and to give at least this much of Ringer's lactate. However, the evidence on this now shows balanced resuscitation is better. Surgical control of bleeding is the key to reducing mortality, which means you need to get surgical control, need to get to a hospital. That means get the patient to a hospital faster. If you want to do it at the field level, elevation and the war situation of tourniquets are now coming up. Went into disrepute, they are now coming up. But tourniquets should not be used without supervision because you end up doing amputations for those long hypoxic limbs if the tourniquet is left in place. So those are the situations you need to understand. The Advanced Trauma Life Support 2008 protocol talks about balanced resuscitation. Again, cardiopulmonary resuscitation, so there is no evidence that mechanical CPRs improve survival. So that's something we have to understand. Increasing technology does not always lead to better. So the golden hour, so E. Brooke Lerner, a scientist, looked at the golden hour. Is it a scientific fact based on evidence-based medicine or something else? It turned out it was a verbal rhetoric of the president of the American College of Surgeons to emphasize early treatment importance that he used this term. Not based on any randomized controlled trial on delay or. So this is important because we do not know whether the delay of 1 hour is possible, 2 hours is possible, 6 hours is possible. So there are different studies which talk about the percentage of death based on delays. However, in this slide that you see, the actual number of death may have nothing to do with the time of delay. It may have everything to do with the historical evolution of modern medicine as such. So whether you need this kind of an ambulance or this or a highly equipped ambulance or an empty shell like this, which we have in most of the rural towns that we have, this is what we need to understand. So how much of speed is important and what all we do in the ambulances. Surely speed matters. That is the understanding everyone has. Lay people also have that. And we should have sirens and flashing lights. Well, there was a major study done by Richard Hunt in a population of 480,000 and looking at 50 consecutive trips, one 911 call, two ambulances were deputed. One following traffic rules, traffic lights, stoppage, everything. The other ambulance driver was told, you do what you want, speed whatever you want to, but get to the destination as possible. Mean saving time in 50 consecutive trips was 43.5 seconds. Why does this become important? Because speed is overemphasized in use of ambulances. And it is only when we started looking at crashes from ambulances killing emergency medical personnel and patients that we are now reviewing this. Now, this is in India because speed is emphasized. Speed is emphasized. There's a high-speed ambulance which comes, loses control, and three people lost their lives. That person walking on the ground and the others inside also. So when you overemphasize speed for golden hour, you end up with disasters, higher incidence of fatal crashes. So it can be dangerous. And the number of crashes of ambulances. So we have seat belts for our patients for our persons traveling in cars and vehicles. But do we have harnesses for all patients that are on stretchers? Because in a crashing vehicle, the stretcher bound patient who is not strapped on the stretcher can be moved onto the back of the ambulance like a torpedo. So we need to understand these little details on high crashes of ambulances as the state of the art. Whereas actually, as helicopters landing in urban areas, in a study which is 14-year long study, they found 139 crashes, 120 killed, 146 seriously injured in this category. Coming to medication, surely when you reach an ambulance, you can get medications to the patients. There is no evidence to show that any medication, except one now, can make a difference. But when we interview ambulance drivers, they'll tell you that most of them are painkillers to keep the patient calm, narcotics or propofol in today's time. However, there's one medication that has come up that can change the outcome in a patient, and that's tranexamic acid. All the available data support the efficacy of tranexamic acid in the pre-hospital setting given within 3 hours. So if you have a delay of a patient being transported, tranexamic acid can save patients provided it is given early on within 3 hours of an injury. Earlier the recommendation to be given intravenously. Now it is moving into intramuscular. High level of evidence is there. This was the crash 2 trial. The number of blood transfusions required with tranexamic acid reduced significantly, and a third of the deaths could be reduced by giving tranexamic acid. That's the crash clinical randomization of an antifibrinolytic in significant hemorrhage with trauma. So death due to bleeding and trauma is reduced significantly compared to a placebo. And that's the only medicine which I would think we need to push for a trauma victim of road crash. Again, spinal immobilization is pushed, but you need to protect the spine more often in an unconscious patient than in a conscious. Conscious patient will tell you, I'm having pain, don't move me, don't move me. But an unconscious patient, you have to be careful. But do we need to use rigid cervical collars and rigid boards and rigid immobilizers? If the transportation time is long, there is the lack of high level evidence in this area also. Cochrane review did not find randomized control trial that met the inclusion criteria for this. And again, uncertain about the final benefit of this. A weak recommendation against pre-hospital use of rigid cervical collar, a strong recommendation against spinal mobilization with isolated trauma. So we looked at Independent Council on Road Safety International is a society that me, Geetam, and some of the other colleagues in IIT are part of, started by Professor Dinesh Mohan. And they try to do an evidence gap map on road safety in specific areas. In specific areas, we looked at interventions that can make a difference to the outcome of the injured, looking at the time and the number of lost personnel, first aid training, stay and play versus scoop and run, time to hospital, drugs abuse. And this is how an evidence gap map result looks like. All these are showing the deficiency nature in this area. So particularly from low-end and medical countries, extraction, there's hardly any papers on that. The occupants extracted from vehicles, most of them were drivers. So we need to protect those drivers by having in the ambulance or vehicle that is transporting the patient those extrication equipment. So the number of people involved with ambulance, without ambulance, looking at a striking lack of research papers from low and middle income countries. So outcome of trauma is not affected by advanced life support on the scene, whereas it makes a difference where you take the patient. The hospital stay is far more important. So Cochrane review on the scene and ambulance advanced life support is not as critical as within the hospital. Again, in out of hospital cardiac arrest patients for all categories, advanced life support are less efficient in survival and neurological deficits in these patients. So improvements in the pre-hospital care is almost useless if quality of hospital care is not improved. So it's important for us, while we push for pre-hospital care improvement, while we push for all the technology that is there, we need to create trauma teams within the hospital, activating trauma teams in advance with a unified national number so that they can be told that there is a poly trauma victim coming to the hospital. Be ready, get him to do, get him to have all the intervention that you do with control of circulation, with CAB, with ABC of resuscitation, all that need to do. We also need to constantly practice this. Need for drills and team building in hospitals is important. So need for skill-based training. So what should we do to save lives and limbs of injured? Scoop and run or stay and stabilize? In countries particularly like low and middle income countries where there is likely to be a delay in the ambulance reaching the site, or in the patients suffering from a delay on site, it's best, instead of staying to stabilize the patient on site and having problems, scoop and run with the patient. So you need to know what is scoop and run: extrication, maintenance of airway, protection of spine, and stopping of hemorrhage. So if I were to put my money, where would I put my money? I would put my money in training trauma capacity of healthcare professionals within hospitals, curriculum change to help understand trauma care, polytrauma, and other trauma victims, legislative change wherever required to protect the patient. So we need to have a unified, comprehensive trauma care system. Why am I saying unifying? Because these are compartmentalized. So the information that you get is fragmented. You can't do research from hospital about pre-hospital care. You can't do outcome studies unless you have a linkage with the hospital. So both are important. Both are important. So all evidence so far seems to suggest scoop and run with tranexamic acid given to the patient in the safest mode possible. Thank you so much. I'll stop here and invite questions.
We will use the usual procedure. So please, if you have a question, write your name in the chat and I will call you out. I have a question.
Yes.
What I realized, I was taking a Swedish driving license. Now it's been quite a while, but it was second driving license in my life. So originally I am from Belarus, so I had a driving license there, and there we studied medical care. So it was a part of driving curriculum. And then in Sweden, I took license for the second time. I have to take the entire course again, but never, ever they talked anything about how to deal with accident victims. And recently I had a discussion with a surgeon, kind of, yeah, your counterpart, so to say. And I was really wondering, so why is it not considered important? Is it because, yeah, I mean, you spend much resources on educating drivers, but you get quite poor quality, and it's indeed that scoop and run which is more important? Like, I don't know, can you comment on that? And what is your recommendation? Should we teach drivers to be
Yeah.
victors?
So the reason I built up the story the way I did was because once I started looking at the papers in the 1980s, there were hardly any papers challenging what we do in emergency care. One of the earliest articles on intravenous fluid was in 1974 by Lewis. He did a computer modeling at that time on the hypothetical need of the volume of fluid for a trauma victim. And that fascinated me. So I kept following up similar papers, then experimental studies on this. So the understanding has evolved. And the more I studied, the more I realized, look at intravenous fluids, we don't know the, we know that it is not so critical in the volumes that we do. We look at the speeding of ambulances, we know this is not so critical to be unsafe speed. Follow the rules, you will still reach the hospital safely. When you look at the medications, no evidence that made a difference, except now the evidence on tranexamic acid. Okay, so you look at components when we broke down, we realized none of them seems to be making a difference. So for the moment, the message is if you have a robust ambulance service, I'm not wanting you to dismantle that. No, continue that. Use the expertise to save as many as you want to, as many as you can. However, you need to know the science of doing this, and therefore, for the moment, the science points towards safe transportation, taking care of airway and breathing, taking care of supplemental oxygen, after extricating it safely from the site, and safe, transporting him safely in a safe vehicle, not necessarily an ambulance. So that amounts to scoop and run. That's all, nothing else.
Yeah, yeah. And I'm thinking also, like, once you get your driving license, you have it for 30, 40 years, you never get your knowledge updated. So there are risks with that as well.
Yes, Alfred, you have a question?
Yes. Shalom?
Shalom?
Yes. Can you hear me?
Yes.
Okay. Well, I've looked at your presentations, very interesting, and you are clearly a scoop and carry advocate as a physician. And I've heard this argument going between the treat at the site and then carry versus scoop and carry, get them as quickly as possible to the hospital. This is contrary to some of the evidence you showed that the survival rate is strongly decreasing from World War I to Vietnam. And unfortunately, we have experience here in Israel that where we advance medical staff to the front line and have greatly reduced fatality rates. So I'm still asking: is scoop and carry is still scoop and carry the best method?
Look, you can have a debate on scoop and uh, run or stay and play. Both you can argue vehemently. The Vietnam story I know, Hans Husum from Scandinavia spent time in Vietnam training village level healthcare providers to take care of trauma victims in the villages of Vietnam and showed that it can make a difference to the trauma victim in the villages. So that is a study. Now, here, please understand, these are people who have long transportation times to specialized hospital care of trauma. Therefore, it can make a difference. The point I'm making as a challenging research question, how much of delay in transportation is safe? So, how much is the golden hour stretchable? That's a research question. How much is the platinum hour stretchable? We don't know. There is no randomized control trial on that. The Vietnam story, yes, it makes a difference. Yes, it is useful. But the point is, in a large urban area, in a large population where you have a large number of trauma victims, how do you deal with them with the healthcare provider? Those were peripheral level healthcare providers reaching the trauma victim and transporting them. So at the moment, average person does not know about it. So if a healthcare provider can reach there and clear their way, yes, do it. Maintenance of a clear airway by lifting of the jaw, average people don't know it. If a healthcare provider can reach it, yes, that's good. So that's not trying to do intervention. If you can't get an intravenous line, I wouldn't waste my time on an intravenous line. If you can't put in start fluids, I wouldn't waste my time on that. I would give an injection of tranexamic acid and get the patient to the hospital. And if I want to control hemorrhage, I would elevate the limb which is injured if it is possible, but not possible in a truncal injury patient. In a truncal injury patient, get him to a hospital setting. He needs to go to the operation room as soon as possible. If he has a ruptured liver or a ruptured spleen, you don't waste time even in the casualty. You rush him straight to the OT, operation room. That's the critical thing. So if one medicine you want to give to stretch your golden hour, maybe not, is tranexamic acid. Are you going to procure cervical collar or this or spinal jacket for these patients? Very, very useful if there is an unconscious patient, but the moment you start using it for longer term, you have other problems. So those are issues that we need. So I am challenging the need for creation of science and evidence sufficiently enough so that I can decide my policy and tell the whole world these are the evidence trauma on the roadside.
Thank you.
Mhm. Thank you. We have one more question. Stefan, you can actually speak up.
Yes, of
Message,
course. Thank you for a very interesting presentation. I wonder if you have any thoughts on, in a few high-income countries, there are some tests about advanced automatic collision notification services, like the DCOL-NET in Japan, and I posted a link in the chat you may follow. I wonder, do you have any thoughts about whether such
Can you just repeat the last sentence? Just repeat the last sentence. Thoughts on?
Regarding advanced automatic collision notification services, like eCall and but giving indications of crash severity. And in Japan, for instance, they have a system like they will employ HEMS services like ambulance helicopters to the site for severe crashes. Do you have any thoughts about if such systems could be effective?
So if you have a system which helps you decide the type of patient that is likely to be received by you in your emergency room, yes, it is useful. It is useful. So, however, on a large scale, they have not been utilized. So they have not been utilized on a larger scale. You need to check what all of these technologies. So you have dispatcher assisted uh, care by on the dispatchers from the periphery in ambulances using technologies of video, teleconferencing, and all those things. So those are all there. But as of today, there is no evidence to show that it has made a difference to the outcome. Why? Because the outcome, if you look at mortality, is determined by the seriousness of injury. However, your job as a surgeon is to ensure that those preventable deaths, so the numbers vary from country to country. So my country has a different number, your country will have a different number. The preventable deaths will depend on your maturity of your trauma system. So the most facilities which have a mature trauma system, your final preventable deaths may be lesser than the other preventable. So whatever you do, your maturity of a trauma system should ensure your trauma mortality, days of stay in the hospital, days of stay in the ICU, disability rates, disability adjusted life years lost, all those must be reduced. That is the bottom line.
Thank you, that's helpful.
I don't know whether I understood your question, whether I've understood the question correctly or not, I'm not sure.
Yes, absolutely. Thank you for the informative answer.
Yeah. I don't know, Stefan, do you know,
Thank you.
do you have like the most recent statistics, how much e-calls are actually used? I remember a report from VTI some years ago, and it was like out of 20,000 ambulance calls, there were, I don't know, 50 handful of those produced by e-calls. So basically it was much less than 1%. So does it really make a difference? And
No, we are investigating that in a project now, and there seems to be not much evidence for the effectiveness, and there's also a lot of problems with false alarms with e-call. So we don't know, but we will look into it and see what data is actually available.
yeah.
So it's for example, if I were to look at the number of patients transported in ambulances in my country, let's assume it's 10%. That means 90% are being transported out of ambulances. So if I put all my money in trying to improve technology, making all the ambulances advanced life support ambulances, and not improve the hospital services, not improve the trauma care within the hospital, not improve the intensive care and the operative facilities within the hospital, I'll only move the mortality from the roadside to the bedside, nothing else.
Yeah. Okay, good. We still have a couple of minutes left, but I do not see any more questions. So the last call.
Thank you. Thank
Yep.
you.
Okay, well, in this case, I think we can round up. So, Mathew, thank you very much for joining us. I know it starts to be a bit late in India. So thank you for staying with us, and thank you for sharing your experience. For me personally, it was a very different perspective from what I'm usually doing in my work. Yeah.
But thank you for having me.
Yes, thank you. And for the audience, so this webinar it is recorded, so there would be a recording published later, so you can share it, and I will try also to edit a little bit, so those few gaps that we had, I will try to remove them. And I hope to see many of you on our upcoming webinars. So end of August with Ralph Reeser, please come and register. Yeah, so thank you once again, everyone, for being with us, and see you soon again.
Thank you, Hedo.
Thank you.
Thank you. Goodbye.
Thank you. Bye.